It's a beautiful Saturday, and today get ready to learn about a new option for treating arthritis in your shoulder, in your back, in your knees, all in a minimally invasive way. We're going to be talking to Dr. Daniel Nathanson from San Francisco. So excited in the San Francisco Bay Area, my stomping grounds. And you'll want to stay tuned and find out about the minimally invasive options to treat your arthritis. So stay with us. Christy, take it away.
Download our apps. Stream us 24/7. Find us online at kdow.biz. This is AM 1220 KDOW. Palo Alto, San Francisco. KDOW.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation. 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Arthritis sucks, and there isn't too much you can do in a minimally invasive way, right? Or at least so we thought. Lots
you know
of
how
pills,
many,
lots of
Kim? Remember we were going to try to do the ping ponging.
we did.
So I'm going to hit you with something.
Uh-oh. I do. You can see it in my hand.
20,
I do.
So
I have it in my thumb. I
25%.
have arthritis. No joke.
I know 25% of U.S. adults, that's maybe conservative, have arthritis. So 25%. So that's like what, 60 million Americans? That's a ton, and it costs a lot of money. So what do you think of that?
It does. Oh my goodness. And you either have pills or you have Voltaren. I am a big fan of Voltaren, constantly rubbing it on my
I know.
on my thumb, which is crazy. My dad actually had it bad enough that he got the embolization on his hands. And remember Dr. Okuno from Japan?
Hmm.
And he talked about getting the embolization in his hands. I don't qualify yet because I can't quite not move it, but at least I know it's there when I'm ready. And Dr. Daniel Nathanson, who is joining us today, he's right here in San Francisco, and he trained with Dr. Okuno, the pioneer of doing what's called embolization, artery embolization of the hand, minimally invasive, cutting off those faulty collateral vessels that are causing the inflammation or feeding the inflammation. So that's exciting.
It's an interest. This is definitely going to be an interesting conversation because I imagine there are a lot of skeptics out there.
Oh,
You know,
yeah.
when I look at embolizing things, I do it when I put a hole in an artery and we need to shut it down, or there's a problem with an aneurysm that we treated where there's an artery that's feeding it and making it grow. So yeah, we're not, the beauty of this show, right, called Breakthrough and Ideas, and so this is kind of a breakthrough, or it is a breakthrough. So looking forward to having this conversation. It should be a fun, spirited time.
But being someone who treats PAD and telling your patients, grow those
Yeah,
collateral vessels, and then you're thinking, oh God, we're going to embolize the vessels.
right.
And
Yeah,
that
the vessel, the
has to make
artery
me
is there
cringe.
for a reason, right? Like it's going to that point for a reason. So this is obviously I would imagine, a very highly skilled group of folks that know exactly what, pinpointing kind of how, we localize radiation for folks with cancer. So you really have to figure out where that artery is going, what tissue bed it's supplying, muscle group, nerve, whatever, and try to knock it out. So this is gonna be a fun conversation because I've got a lot of questions.
Okay, so let's kick off the conversation with a moment of inspiration.
Dr. John Phillips, spectacular vascular moment of inspiration.
So this is an interesting quote about just being a skeptic and getting it wrong, because again, I imagine the there's data out there for this. Not a lot of randomized controlled trials and whatnot, but there's data. So this is a good conversation to have about embolization. But so Steve Ballmer, who's behind Microsoft, I think one of the co-founders, his comment about the iPhone in 2007 was, quote, "There's no chance that the iPhone is going to make any significant or is going to get any significant market share." So he got that wrong. Are we going to get this wrong? I don't know, because the iPhone is ubiquitous and it started the smartphone revolution. So we'll see.
That's such a good quote because you have to think about, well, who's the skeptic? Who's saying it's not working? Is it someone who is arguing for their own limitations and hoping that their influence will be the louder voice? Or is there truly evidence behind the fact that that particular innovation is not going to succeed?
Yeah, I mean, again, I think you look at if you dive into the data, I imagine that's probably like a lot of things that start out, right? I mean, make sure it's safe. It's small cohorts of patients, probably single center. Um, so again, there's and what we need. We all ask for more randomized controlled trials. I was just reading a randomized controlled trial about the different type of drugs that we use on balloons to treat blockages in the arteries in the thigh. Um, Small patient population, small. I mean, so again, you interpret the science and the data, based on kind of the confines of who's designing the trial and what the question they're asking is, and how they're getting their answers. But nonetheless, I mean, I know people that have had the procedure, at least in the knee, and it's helped them. So what the heck? I mean, explore other locations, and I think that's what we're here to talk about.
What do you think, Dr. Nathanson?
Yeah, well, we've taken a very deep dive on the embolization techniques. The idea is that we are removing the problem vessels associated with inflammation. And I think of a lot of these conditions, arthritis and this is what we found, is a state of chronic inflammation. So if you have a wound in the arm and it gets beefy and red and then you get healing, that's great. And once it's healed, then the inflammation goes away. But with arthritis, we don't have the capacity to grow back new cartilage or smooth out the bone. And so this inflammation has actually been shown to be destructive. It's not helpful in conditions of chronic arthritis. And if we can target the abnormal blood vessels, uh, reduce the number of abnormal blood vessels, then we can directly impact the inflammation. And there is now a lot of data and a lot of our personal experience to suggest that this is really effective. But I agree, there are going to be skeptics out there. We're trying to, as a vascular surgeon or cardiologist, preserve blood flow, not block blood flow. So it's a bit counterintuitive, and I think is the basis for a great conversation. So
Yes,
I'm happy
and
to be here today.
we
Yeah.
started the conversation about artery embolization a little more than a year ago. So, looking forward to hearing more from Dr. Daniel Nathanson coming up next in the break, where he's going to share maybe some of the new data with us. Also, being a vascular surgeon looking to protect blood flow, and yet he's taking it away. We're going to find out a little bit more about the science behind that. So, that's next. Stay with us right here on the Heart of Innovation. Don't go away. I would love
All right.
to. I always loved Dr. Okuno talked in a way that he started out because he was a cancer doctor, right? He got the idea to do the hand like from cancer. So people need to understand, I think, what you mean by abnormal blood vessels, that how these vessels grow, how the tumor kind of tricks the body into feeding it. I had a fibroid in my belly and you have artery embolization for that as well. because you take away the blood flow. So the whole idea is, how does the body, how do these, how do these foreign things, the inflammation, the tumors, the fibroid, how do they trick the body to give them blood flow to succeed, to be able to thrive? And that's kind of the theory behind that. So I wonder if we could start off segment two. What do you think? Just really kind of understanding that.
Yeah, I think we need to explain to folks what embolize means, get into kind of like the ground rules, lay the foundation. So we've got 9 minutes and 15-ish seconds, I thought I saw. So we're
Yeah,
Oh, that's
plenty of
great.
time to chat.
yeah.
Chris D, are you airing the circulation challenge commercials? Just want to make sure.
Yeah.
Okay.
30 seconds.
In retirement, Rob Black will share market happenings and trends. That's Saturday, September 12th, 10 to noon at the Nathanson Community Library in Lafayette. Space is limited, so sign up today at robblackshow.com. That's robblackshow.com. Investments not FDIC insured. Past performance does not guarantee future results. Not on offer to sell or a solicitation to buy any security. Member FINRA SIPC.
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. It also is a beautiful day here in Columbus, Ohio, as is evidently in San Francisco. In fact, I thought, Kim, you were going to start singing It's a Beautiful Day in the Neighborhood for Mr. Rogers. We can do that later. But let's get back to the conversation with Dr. Nathanson about embolization. Can you lay the groundwork for us? What does embolization mean? What are we talking about? We're talking arteries, and just a little bit of history behind this process and how it evolved to where you're at right now.
Yeah, absolutely. So, Dr. Yuji Okuno in Japan was doing research into tumors and cancer, and interventional radiologists will frequently do a procedure, where they release very small particles to the area of the abnormal blood vessels to block those blood vessels. And that release of particles to block blood vessels is embolization. And that's what we mean by embolization, blocking abnormal blood vessels. And what we found is that with tumors and with arthritis, there are these factors called cytokines that are growth factors that are produced in the setting of inflammation. And it's very similar to cancer. And the growth factors lead to the development of these abnormal blood vessels in a process that we call neoangiogenesis. So these abnormal blood vessels are developing, and he saw that he had a patient with a tumor, but also with arthritis. And he saw that the blush, you see a blush when you do the angiogram, sort of like a cloud of dust appearance, was similar in the area of arthritis than as in a tumor. So he came up with this idea that maybe if we embolize these abnormal blood vessels in the arthritis, then we can achieve impactful improvement in symptoms, including stiffness, pain, and function.
And so basically, I have to ask the stupid question. How do these tumors and the fibroid, like what I had, and because you have uterine fibroid arterial embolization, I can't remember exactly what it's called, and arthritis, like how do they trick the body to grow these vessels? I mean, we can grow collateral vessels, right, to reroute blood flow around blocked arteries. Like that's doing really good things with every step you take. But how do these things that are not good for you end up attracting these blood vessels to grow and feed them?
Well, in cancer, the cancer itself is hijacking the body's normal mechanisms. There's times when additional blood growth can be useful in terms of wound healing or with collateralization around a blocked artery so that you get improved flow even when you have a blocked major artery. And those same mechanisms are hijacked in the setting of arthritis and cancer. And so the body with arthritis is trying to heal something. And the inflammation is in most settings a beneficial process where you're recruiting all these different factors that contribute to wound healing. But with arthritis, there's no healing going on, so the inflammation just stays, but the healing doesn't come along with it, and the inflammation itself becomes a problem.
So, Daniel, let me ask you this. We spend a lot of time on the show talking about collaterals and tiny little vessels that are kind of feeding areas of wounds, and that's a good thing, right? I mean, that blush that we see in a wound bed and on an angiogram that we're treating is a good thing. So it's a little bit counterintuitive for some of our listeners to say, well, wait a second, these vessels are good things, right? But what I guess, and you said abnormal blood vessels. So how do you guys differentiate between those two?
Yeah, really good question. So, um, we have a patient, we need to verify that they have arthritis. We do a workup, and they meet certain criteria in terms of radiographic findings and findings on imaging studies. And then we decide, well, this patient is a good candidate for one of these embolization procedures. And then there's about 7 or 8 different branches that go to the knee joint. We sequentially catheterize each one of those branches and we put a little bit of contrast dye into the branches and we see a blush. And as I mentioned before, it's a cloud of dust appearance. And when we see that blush, then we do the embolization with particular types of particles that are designed to go through the normal vessels, preserve the normal vessels, and then block off the abnormal vessels. So in terms of deciding which vessels to treat, it's generally based on what we see during the procedure.
And so Douglas, who's watching, and one of our PAD warriors, is asking in our chat, just he wants to make sure we're not talking about cutting anything. We're literally talking about dropping particles, the mix of antibiotic, like is it an antibiotic and the contrast dye that end up coming together and creating this formula that blocks the abnormal vessels?
Absolutely, Kim. So, yes, the first part of that, there's no the surgical incisions. This is a very small catheter. It's actually smaller than the catheters that we usually use for PAD. There's something called a sheath that we use for access. We don't need to use a sheath. We just use a small catheter. It's just like an IV, a little bit bigger. And then we feed that down to the area of the knee, and we use the contrast. And then the second part of that question is what do we use for the embolization? And all the original research was done actually with an antibiotic called imipenem. So if patients are not allergic to penicillin, then we'll use that imipenem, we'll mix it up with contrast, and we'll use that as our embolic agent. And the nice part of the imipenem is that it is dissolvable, what we call resorbable. So in the normal vessels, it'll just dissolve. But the abnormal vessels are very sensitive to being blocked for even a short period of time. So those ones will all go away. And along with those abnormal vessels, there are abnormal pain conducting nerve fibers, and they also go away. So it's minimally invasive, and it's an advantage that we're able to use these particles that are able to dissolve because it makes it much safer. You don't have to worry about them going to the wrong spot.
And Douglas is asking a follow-up question about how long it lasts. How long do they stay closed?
I'm really glad that you asked that question, Douglas. So really good question. There are millions and millions of knee injections that are done every year in this country, steroids or gel, and most of my patients who are interested in the GAE, the embolization procedure, have already had many of those injections, and they generally last a few months. And a typical story is, well, they last a few months, then the next one lasts 2 months, and then the next one lasts for a month, and then the next one doesn't work at all. And then pick up the phone and call Dr. Nathanson because I'm out of options. Um, and the nice thing about the embolization procedure is that it can last for 2 to 3 to 4 years. It's very durable as opposed to the injections. So, and I think the hypothesis is that it's because it gets at part of the root cause of the problem, which is the inflammation.
And coming up next, right here on the Heart of Innovation, we're going to find out where in the body this arthritis can be treated using these minimally invasive approaches. Hint, I mentioned it in the beginning, so stay with us right here on the Heart of Innovation on KDOW for more.
All right, Marcia, do you wanna ask your question right off the bat when we go back on live, or what is your question if you don't?
Well, I wanted, you may know this, Dr. Phillips, but Dr. Nathanson doesn't. I have 100% blocked full, what do they call that? Full metal jacket, but they're all blocked. SFA down into my popliteal, but now I have arthritis in my knee. And the more I walk, the worse the arthritis is. But if I back off on my walking and hiking, then it eases up to some degree. So am I a candidate for something like this? And who
Well,
does it? You're a
I want to
vascular?
actually, do you mind? That's a great question.
Yeah, we'll
Do
ask
you
that
mind if
live.
yeah, do you mind, Marcia?
I
Because
think
that's a
that's a
great
great
question.
segue into like who are candidates for this, because
Yeah.
I mean clearly somebody who comes in with their wrist hurts for a week, you're not gonna, or whatever, right? So
Yeah, yeah, of course, and also touch on the response rate is quite good, but it's not 100%. It's about 70 to 80% of patients will have a really good response. So I'm
Actually pretty
always
good.
yeah, which is good for a minute. I mean, most patients are jumping up and down with their hands in the air. Well, they would be if their knees didn't hurt so much. But the idea is that you're really able to get a very good response rate, but you also have to set expectations. There's about
sure.
20 to 30% of patients that it's going to be the same. Not worse, but the same.
And we also, so we'll get to Marcia, and then Potsy Allen has a question. It's great. We're stirring up a good discussion. And then after that, it'd be great at some point. We're only in segment 3, so we can get through those questions. But at some point, I want to go through shoulder because I'd never had anyone talk about the shoulder, the back, which you're not doing yet, but it'd be interesting just to have that conversation. And then also, as Dr. John was mentioning, the contraindication for some with PAD, because other doctors were saying, actually, this is the answer for PAD patients who can't have a knee replacement as long as you have a doctor who knows what they're doing and takes that into consideration. Oh, and Wanda has a great question, actually, when we get into that about the hip, why the hip's not being done, because I haven't seen anyone do hip
I'm
for
I'm doing
arthritis.
hip. I've done a few
Oh,
hips. Yeah, we have one next week actually.
oh, so that'll be interesting.
Yeah,
So that'll be interesting to talk about the indication for
Yeah.
that versus hip replacement.
yeah.
30 seconds.
That's also because people have to wait months to get the hip replacement, and that sucks. We went through it with my dad. It's awful.
Yeah, yeah.
So that way you could almost schedule out your hip replacement even further and have this as a good bridge, maybe.
800-279-6159. That's 800-279-6159.
1220 KDOW.
Welcome back to the Heart of Innovation, For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Happy Saturday, everybody. A great day to take a walk, but man, if your knees are killing you or maybe your shoulder, it's a little bit more difficult. So continuing the conversation about embolization for arthritis. So Dr. Nathanson, let's talk about the indications here, right? So not everybody who has arthritis is going to want this procedure. It's typically a little bit more down the line and you've failed some other treatment options, correct?
Yeah, absolutely. We do what's called a WOMAC questionnaire, which is about 30 or 40 questions, and it's a 0 to 4 scale. In things like getting out of the car, walking up and down the stairs, when are you having pain? Is it at night? How severe is it? How long lasting? Because we really want to get a good sense for a baseline in terms of how much disability our patients are experiencing. So if the score is very low, then the procedure probably doesn't make sense. By the time our patient gets to us, the score is generally about 50, 60, 70. I've had patients, it's a 96-point scale, and I've had patients all the way up into the 90s experience significant improvement. So you want to ask those questions of the patient to make sure that they're really having some significant disability. Then we have to make sure that they actually have arthritis. An MRI is great, but it's not necessary. Most of our patients, all of our patients have an X-ray. It's very uncommon to have an MRI and no X-ray. And on that X-ray, we're looking for arthritis. In arthritis, there is something called a KL score. Again, 0 through 4. 4 is severe, 3 to more moderate. And what we found is that while many of the severe arthritis patients do respond, if it's KL3 or 2, that's almost kind of our sweet spot because the inflammation is significant, but the destruction isn't yet as significant. And we found for those patients, we can really halt the progression of the arthritis and get great results. So while the severe is certainly not a contraindication, and many of our patients have severe arthritis, we are really interested in the patients that are not ready for a knee replacement, maybe because they're too young. A knee replacement when you're 40 might mean that you're looking at 3 knee replacements in your lifetime because they have a lifespan, usually of about 20 years. Or medically fragile older patients who just aren't, from that standpoint, a candidate for a knee replacement. Or it can sometimes be, well, there's not that much disability, but I can't play pickleball the way I'd like to. So that's another category of patients. Not ready for a knee replacement, but have arthritis and are significantly impacted by it, but not ready to go to knee replacement.
Gotcha. So we're going to call on, we've got the cool thing about the show, live studio audience and getting into indications. Marcia, one of our patients with PAD has a question.
Thank you. Yes, I might be the patient you're talking about. As far as I'm not quite ready for a knee replacement, but I have PAD, full metal jacket from my hip to my knee, but I walk a lot. And the more I walk, the more worse my knee is. And if I lay off my walking and get to about 12,000 steps a day, then my knee feels better. But it's a catch-22. I'm supposed to walk because I don't have blood flow, but when I do, my knee gets bad.
Mhm. Yeah,
And so am I even a patient with, I have a lot of collaterals evidently, but I also have severe blockages.
Yeah, what we worry about with severe peripheral arterial disease is that we are embolizing that critical blood vessel that is the one that is going to the calf muscles and making it so that you're walking isn't impacted even more. So we'd have to think long and hard in that case. Now, if it's a mild blockage, that's something that we can potentially think about. But when you go to the international meetings and they talk about contraindications, severe peripheral arterial disease with a blocked SFA and popliteal artery is what is conventionally kind of number one, either one, two, or three on the list of don't go there areas. So I do think that with the resorbable embolics, with imipenem, it's certainly safer. But especially in the early stages, have a tendency to be very conservative. And as a vascular surgeon or a cardiologist who does peripheral interventions, our focus for a patient like you is always going to be, let's do whatever we can to preserve that distal blood flow, to make it so that we're not doing anything to make that worse. That has to be our priority. So I treat patients, it's a case by case basis, but we'd have to think long and hard about doing an embolization procedure with a blocked SFA.
We've got 2 minutes left. Alan, you have a question.
Hi, doctor. I have chronic pain in my shoulder, and I have PAD. And the chronic pain in my shoulder I've had for 8 years, and it's quite severe. I was in the hospital last year 5 times. Um, Ultimately, they put me on an opioid drug, and that brought my pain down to the point that I could function. I've never been told that this pain might be related to arthritis. They think it's nerve related, but they told me they'll never really know what's causing my pain. Is this a treatment that you think I should explore? Or I'm thinking that if it had anything to do with arthritis, they would already know that. They would see that from all the imaging I've gotten. So I'm thinking it probably doesn't apply to me, but I'd like to know what you think.
Coming up next, right here on the Heart of Innovation. That's a great teaser. Thanks, Alan. And Dr. Daniel Nathanson will tackle that question and more next, right here on the Heart of Innovation on KDOW. Stay with us.
What if?
Thanks, Alan. Beautifully said.
Yeah,
Kill two birds with one stone. You want to hear about the shoulder now?
uh,
Yeah, I want to get into shoulders and hips and, um, you know, I've kind of literally there's a whole podiatric bandwagon against plantar fasciitis. So we don't even talk about that because my board member ended up being one of the people that is 100% against the plantar fasciitis. I don't know if you've had experience with that yet. Um, but I thought that
Like
was,
doing embolization for it?
yeah,
Oh.
totally.
and they're
100%.
against it for what reason?
They think it can cause damage. It's not necessary. Just a money-making ploy.
Okay.
Yeah.
Since we have some time between the break, I'm curious from like a technical standpoint. You're I use microcatheters to kind of get into these arteries. And do you shoot contrast to kind of see like that blush that you're looking for? How can you tell, the technical portion of it?
Yeah, so it's a 5 French catheter, no sheath, and the 1.7 French microcatheter. I'll do an initial run from the distal SFA and get a sense for where the branches are, and then using the base. So this is pure IR, and it's actually been these skill sets carry over to PAD too, and it's a different way of kind of handling a similar situation. But there is, I've done lots and lots of catheterizations over the course of a 20-year career, thousands and thousands. So a lot of experience with the catheters inside vessels, but this using the microcatheters, not as much. But yeah, we will take the base catheter, put that up against the ostium of the vessel, feed the microcatheter through the base catheter, shoot a little bit of contrast, and then we'll be able to see the blush. And when we see the blush, then we do the embolization. If it's imipenem, I'll have a very low threshold. I'll embolize almost all the vessels, even if I see just a little blush, because we really want to make sure that we're kind of checking every box to make sure that we're being thorough. But yeah, the technique is,
So these are not, you're not using coils or glue or are you in some
Yeah,
instances?
so I use imipenem for all patients that are not penicillin allergic. So for the 15% or so that are penicillin allergic, we'll use microbeads. The universities are generally not able to get access to imipenem.
30 seconds.
There are purpose-built, not yet FDA-approved resorbable particles, and we just don't have access to them yet in the US, but we probably will by next year.
So does the imipenem, and maybe we can talk about this in the next segment, but does the imipenem actually, is it occlusive to the blood flow, and the blood flow is just dead or gone, or does it?
AM 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
All right, let's get to the answer for the question about the shoulder. Is Alan's shoulder an option with embolization?
Yeah, so what I would say is that we do need to verify that there is arthritis there. And my guess is that there is likely a component of arthritis, but we do need to verify that. PAD in the legs is not a contraindication to doing a arm-based procedure because we know that almost all patients with severe PAD in the legs will still have patent arm vessels. There are exceptions, but most patients. So I would say that if you were my patient, I would look through all the imaging, order new x-rays if needed, see if there's a component of arthritis. And if there is one, by all means, you'd be a candidate for a shoulder embolization procedure.
Okay,
And
thank you.
Thank you, Alan. And Marcia had another question about the hip. Marcia, go ahead.
I also have, my arthritis probably worse in my hip, but it's on the opposite side where my blockage, I don't have any stents in that leg. Would I be a candidate for a hip embolization?
Embolization, yeah. Absolutely. If the PAD does not involve the iliac vessels, which are the ones kind of between the belly button and the groin, then you'd be a candidate for it, especially if you're not penicillin allergic, because then we can use the imipenem, which is resorbable.
I do have 2 stents in that iliac on that side.
So that, we would have to look. We'd
Okay.
probably get what's called a CT angiogram. If the stent is wide open with no stenosis or other issues, then, then it would be reasonable to have that conversation. But if it's, close to occluded, then it's probably not a great idea.
Thank
And
you.
we'll get to Betty's question. She's watching online in just a moment, but since we're talking about hips, I know with my dad that he had to wait months when he was bone on bone. He had to wait months to have surgery for a hip replacement. I'm wondering if this could be a really great bridge that maybe someone could. How long do the hip embolizations last? And would this be a good opportunity to say, hey, I could actually schedule out my hip replacement for maybe a year later because this is something that's good in the meantime?
I think that that's entirely possible. We do not yet have as much data for the hips as we do for the knees, but we do know that they are quite durable. The hip replacement operation is a bit easier to recover from than the knee replacement operation. So I think for that reason, the threshold to going to surgery is a little bit lower with the hips as opposed to the knees. But there are many patients that are not candidates or can't get access to the surgery in a timely fashion who would be good candidates for a hip embolization.
And sorry, real quick, insurance, is that an issue? A lot of pre-certs and things, or no?
Yes, so Medicare is not a problem. We in San Francisco, we're a Medicare certified ambulatory surgery center as well as an office-based lab. So for many of the private commercial insurers, they're a case-by-case basis. I would say it's about 60 to 70% approval in that population. But we have some flexibility there because we can do it in our um, when we're an office-based lab, which is every Monday we're an office-based lab, and Tuesday through Friday we're an ambulatory surgery center. So there are, this is the system. These are the cards that we've been dealt, and we find a way to take care of our patients. And in Medicare, it's no problem, but it is a bit of a case-by-case basis for the commercial insurers.
And for Medi-Cal, I don't mind calling them out. I'm having more issues with Medi-Cal patients in office-based facilities and having any sort of even revascularization procedures to save a leg from amputation. So I could imagine it's also trouble when it comes to artery embolization, that there's a bit of a challenge there. But Betty has a question. She says about 18 years ago, she had a partial knee replacement, and now the right side that was not replaced as painful. However, she does have factor V and gastrointestinal AVMs. She has been treated with argon coagulation and iron infusions. She can't take blood thinners, even though she has PAD and CVI. Would this procedure potentially be possible? She does try to walk every day.
Yes, no, I think that it would. And I wasn't sure if the question was going to the side with the surgery, because that's another question that we get. There are patients that have had a knee replacement that have ongoing pain. And we have done embolizations for those patients with good results. But in terms of those medical issues with the factor V Leiden and the AVMs, I do not think that that would present a contraindication.
So, all of the areas for embolization, we have the hands. My dad had his hands done. There's the knees. That
Yeah.
seems to have the most extensive data. You talked about the hips, a little bit about the shoulders. Anything I'm forgetting?
Yeah, so let's start from we've done fingers, hand, wrist, golfer's elbow, shoulder. So golfer's elbow and tennis elbow, shoulder, hip, knee, Achilles tendinopathy, a lot of tendinopathies in the foot with good response, and including patients who were told that they would have to have complicated ankle reconstructions that have done well with embolizations. Achilles tendinopathy is a big one. A lot of sports related chronic stress issues it's very good for, like jumper's knee and patellar tendinopathy. Um, so yeah,
How,
we've done pretty
it sounds
much,
like boom
yeah.
from head to toe. Then we've got probably a minute and a half left. But so, how do you put guardrails around this procedure, knowing that, I mean, there's a lot of joints that hurt, there's a lot of arteries that go to it. I mean, I imagine anybody and their brother could start, or sister for that matter, could start doing this, and maybe turn it into another four-letter word like atherectomy.
Yeah. Well, I would say you want to find somebody who is very, very comfortable with catheters in vessels. So not every vascular surgeon is as endovascular focused. And so there's a lot of operator issues there. The guardrails in terms of which patients to offer it to, uh, well, you have to be very careful about documenting the dysfunction and documenting the disease. Uh, there has to be arthritis. There has to be tendinopathy. I'm very hesitant to treat a patient that hasn't already seen an orthopedic surgeon or a specialist or hasn't gone down the road of multiple more conservative interventions, who isn't really struggling with the issue. It's not for everyone, but I have not had significant complications or problems with it. The risks of the procedure are low, and it's hard to turn people. I had a patient who had
That we're going to
20.
hear about in just a moment. Good
Okay.
cliffhanger, Dr. Nathanson. We'll hear about that patient. We'll hear about the recovery time. And we'll also hear about the potential for backs with Dr. Nathanson, back stenosis. Stay with us right here on Heart of Innovation. Don't go away.
All right.
And Wanda, oh, there's Lori. Lori, can you mute yourself? I waited to, because I know you always have mute. There you go. You're always unmuted when you come on and it's noisy. So just stay
Oh, it's
muted
on
if
mute
you can.
again. I'm sorry.
That's okay. That's okay.
No, you do it. I don't.
I can do it for you. There you go.
So the next segment is usually what?
It's only 4 minutes.
Oh, no, 3 minutes.
3 minutes.
Oh boy.
And we have to cover the story. They have a question about recovery time, but we also, he's going to learn about backs. So people always ask about back stenosis. So it's important we didn't cover that, just to cover that. So I'll let you two handle all three of those.
Let's do it.
Okay.
And you're going to be busy.
Dr. Nathanson, the speed round.
Mm-hmm.
Yeah, the back is quick. The recovery that's a quick question to answer. What was the third one going to be?
You were mentioning
Your
a patient.
story.
I think you were going to.
Oh, yeah. Man, it's a patient with 20 years she actually came from Pittsburgh to see me because she's a relative of one of our staff with 20 years of hand arthritis, and she was just overjoyed. I mean, it's a really amazing result. So, it's something, I get excited about this, and it's hard to kind of put the guardrails on it sometimes because it's so helpful for so many people, that you want to kind of, have that impact.
Mm-hmm. Yeah, it's nice. And it sounds like it's pretty immediate too. I mean, obviously the flow is interrupted pretty quickly.
Not for every patient, but
Okay.
it's sometimes you get a patient that's immediately it's responsive, and something, oh, is that the
30
anesthesia,
seconds.
but we tell patients.
Oh yeah.
It can be. We could talk about that too.
Are they conscious sedation, I'm assuming?
Very light sedation.
Yeah. Okay.
It's Clean Comedy Night with Dennis Gaxiola, Friday, September 25th at Faith Fellowship Foursquare Church. Get your tickets at kdow.biz. kdow.biz.
KDOW 1220 KDOW.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
All right, speed rounds. We've got 3 minutes left. We've got to cover the patient you were mentioning, which I think kind of dovetails into expectations and recovery time, and then finally hit on some new territories, which potentially the back, right, Dan?
Right. So the patient with hand arthritis been suffering for 20 years. came from Pittsburgh to see us, and by the time she got on a plane 5 days later, she was overjoyed. Hands more function, less pain, was able to sleep through the night. So a really nice result there that I wanted to bring up. In terms of recovery, you go home about an hour and a half after the procedure with baseline activities. You don't have to be non-weight bearing or anything like that. The sedation for the procedure, very light sedation. You can even do it with local anesthetic only. And then, John, remind me, what was the third question? What am I
In
The
missing?
regards
back.
to the back.
Yeah,
Oh, the back.
yeah, I mean, that was the tease, but it's the back.
Yeah. All right. Okay. So we have not done it. So Dr. Akuno in Japan is doing the back. That'll be phase two. We have not yet encroached on that territory, but my guess is that we will within the next year to 2 years.
That's incredible. And what about the evidence? Are we seeing more and more evidence? And where's the most substantial evidence backing these procedures?
We need more data. There are randomized control trials out there, but in the next year, we're going to get lots and lots of new data. The data that we have is many, many patients, but it's single center cohort by and large. So we are going to stay tuned. We can have a follow-up discussion. A lot of that's going to be presented at the CIRSE meeting, which is the International Interventional Radiology meeting in just a couple of weeks. So we are going to more to come.
And so, Dan, selfishly as a physician, and there we have a lot of physicians that listen in. How do we get trained on this? I mean, obviously, come see you, but are there courses and stuff that we can look into?
Yeah, so I did a very, very deep dive with every possible resource that I could find, including, everything that's online. There's a course in Paris. I went to that twice. I went to see Dr. Akuno in Japan for a workshop. But there are many centers in the US that are doing this, and there are options.
All right.
Thanks so much. San Francisco Vein and Vascular Institute.com with Dr. Daniel Nathanson.
Real pleasure, Kim. Thank you so much.
Awesome. Thank you so
right.
much, Dr. Nathanson. We really appreciate it. And we're going to head out on YouTube. We're going to jump back in a few moments on another episode we're doing about the Great Circulation Challenge, the greatcirculationchallenge.org, which Dr. Nathanson, are you going to start a San Francisco vascular team?
100%.
Yes. So make sure, like the video, subscribe to our channel, and make sure you go to the greatcirculationchallenge.org. We're starting on Tuesday.
Sounds great.